Alcohol use disorder. Clinical picture. Although alcohol is a sedative, it creates an initial feeling of euphoria. This is probably related to decreased inhibitions. A duster of behavioral and physical symptoms characterizes alcohol use disorder. The full criteria for alcohol use disorder are listed in the DSM-5 box. Severity is based on the number of symptoms, mild, 2 or 3. Symptoms, moderate, and severe. DSM-5 criteria for alcohol use disorder. A problematic pattern of alcohol use leading to clinically significant impairment or distress, as manifested by at least 2 of the following, occurring within a 12-month period. 1. Alcohol is often taken in larger amounts or over a longer period than was intended. 2. There is a persistent desire or unsuccessful efforts to cut down or control alcohol use. 5. A great deal of time is spent in activities necessary to obtain alcohol, use alcohol, or recover from its effects. 4. Craving or a strong desire or urge to use alcohol. 5. Recurrent alcohol use resulting in a failure to fulfill major role obligations at work, school, or home. 6. Continued alcohol use despite having persistent or recurrent social or interpersonal problems caused or exacerbated by the effects of alcohol. 7. Important social, occupational, or recreational activities are given up or reduced because of alcohol. 8. Recurrent alcohol use in situations in which it is physically hazardous. 9. Alcohol use is continued despite knowledge of having a persistent or recurrent physical or psychological problem that is likely to have been caused or exacerbated by alcohol. 10. Tolerance, as defined by either of the following. A need for markedly increased amounts of alcohol to achieve intoxication or desired effect. B. A markedly diminished effect with continued use of the same amount of alcohol. 11. Withdrawal, as manifested by either of the following. C. The characteristic withdrawal syndrome for alcohol. D. Alcohol is taken to relieve or avoid withdrawal problems. Specify if. In early remission, after full criteria for alcohol use disorder were previously met, none of the criteria for alcohol use disorder have been met for at least 3 months but for less than 12 months, with the exception that criterion ad may be met. In sustained remission, after full criteria for alcohol use disorder were previously met, none of the criteria for alcohol use disorder have been met at any time during a period of 12 months or longer, with the exception that criterion may forth be met. Specify if. In a controlled environment, this additional specifier is used if the individual is in an environment where access to alcohol is restricted. Epidemiology. Alcohol use disorder is far too common. In 2018, 148 million people in the United States were estimated to have alcohol use disorder. About 401,000 adolescents aged 12 to 17 had a past year alcohol use disorder. Young adults are particularly affected by alcohol use. About 34 million young adults, aged 18 to 25, are estimated to have had this disorder. About 110 million adults 26 and older had an alcohol use disorder in the preceding year. Rates of this disorder are higher, with almost twice the prevalence among adult men versus adult women. In general, American Indians/Alaska Natives have the highest rates for alcohol use disorder and are disproportionately affected by alcohol problems. Prevalence rates are higher in whites, followed by Hispanics, Blacks, and Asian Americans and Pacific Islanders. Comorbidity. Bipolar disorders, schizophrenia, and antisocial personality disorder are associated with an increase in rates of alcohol use disorder. Major depressive disorder is a risk factor for and a result of alcohol use disorder due to alcohol's depressant qualities. Alcohol may also reduce the immune response and predispose users to infection. Risk factors. Biological factors. Genetic. Alcohol use disorder runs in families and about 40% to 60% of the risk comes from inheritance. Monozygotic twins are more likely to share alcohol use problems than are dizygotic twins. Monozygotic male twins are more likely to share alcohol use disorder than are female twins. Up to a 4-fold increase in risk occurs in children of affected individuals when the children are given up for adoption or raised in other homes. There is some evidence to suggest that some genes may reduce the risk of alcohol consumption by impacting alcohol metabolism. For example, certain alleles of the alcohol dehydrogenase and aldehyde dehydrogenase genes can cause a buildup of acetaldehyde that creates the classic flushing response, Ebert, thin and small, 2016, neurobiological. Individuals from families with a history of alcohol misuse have altered amygdalar, hippocampal, basal ganglia, and cerebellar volume. Functional magnetic resonance imaging studies show altered inhibitory control and working memory brain response in these individuals. There may be brain activity differences in areas involved in emotional and instinctual reward processing. Environmental factors. Social. Adolescents may be strongly influenced by their peers to engage in substance use. Alcohol, which has been referred to as a social lubricant, may increase an adolescent's feeling of belonging. Using alcohol, tobacco, and marijuana at an early age is strongly associated with coming from a home with low parental supervision. Cultural. Substance use may create a sense of community and belonging in otherwise isolated individuals. The lifestyle of individuals who use substances may even seem alluring and dramatic to vulnerable people. In some cultures and religions, alcohol use is not accepted, and any use would be considered deviant. In other cultures, alcohol use is a regular part of everyday life, and the amount of consumption would be alarming to people outside the culture. Muslim-majority countries such as Pakistan, Libya, and Saudi Arabia have prohibitions against alcohol. In Afghanistan, it is illegal for citizens to purchase alcohol, but there are still places for foreigners to drink. In the United States, some Christian denominations such as Pentecostal, Baptist, and Mormon reject the use of alcohol. Types of problematic drinking. Amounts of alcohol that are considered safe vary depending upon individual factors. Identifies the numbers of drinks that are considered acceptable, depending on the gender, age, and pregnancy. Excessive drinking is described by two different terms. Binge drinking refers to drinking too much alcohol quickly. For women, this amount is 4 or more drinks within 2 hours. For men, this amount is 5 or more drinks within 2 hours. Heavy drinking is characterized by drinking too much, too often. 8 or more drinks in a week constitutes heavy drinking in women. Men who drink more than 14 drinks in a week are considered heavy drinkers. Table 223 Maximum safe number of drinks based on population. Women, pregnant, adolescent, older adults. Men. 4 day. Week 14. 3, 7. 3, 7. U.S. Department of Health and Human Services. 2015-2020 Dietary Guidelines for Americans. Retrieved from Alcohol Intoxication. The legal definition of intoxication in most states requires a blood concentration of 80 or 100 mg ethanol per deciliter of blood. This concentration may also be expressed as 0.08 to 0.10 g/dl. Signs and symptoms of alcohol intoxication based on blood alcohol are 20 mg per deciliter, 0.02 alcoholic drinks, slower motor performance, decreased thinking ability, altered mood, and reduced ability to multitask. 50 RNG/dl, 0.05 alcoholic drinks, impaired judgment, exaggerated behavior, euphoria, and tower alertness. 80 mg per deciliter, for alcoholic drinks, poor muscle coordination, altered speech and hearing, difficulty detecting danger, impaired judgment, poor self-control, and decreased reasoning. 100 mg per deciliter, 5 alcoholic drinks, slurred speech, poor coordination, and slowed thinking. 150 mg per deciliter, 6 alcoholic drinks, vomiting and major loss of balance. 200 mg per deciliter, 0.20 to 10 alcoholic drinks, memory blackouts, nausea, and vomiting. 300 mg per deciliter, more than 10 alcoholic drinks, reduction of body temperature, blood pressure, respiratory rate, sleepiness, and amnesia. 400 mg per deciliter, 0.40 vital signs and possible death. Intoxication is based on a number of factors, including how quickly the alcohol is consumed. Quicker ingestion results in higher levels of blood alcohol. In the United States, a standard drink is one that contains about 14 g of pure alcohol. Illustrates the relative amount of alcohol in standard drinks. Alcohol withdrawal. Alcohol withdrawal occurs after reducing or quitting alcohol after heavy and prolonged use. The classic sign of alcohol withdrawal is tremulousness, commonly called the shakes or the jitters, which begins 6 to 8 hours after alcohol cessation. Mild to moderate alcohol withdrawal includes agitation, lack of appetite, nausea, vomiting, insomnia, impaired cognition, and mild perceptual changes, both systolic and diastolic blood Pressure increases, as does pulse and body temperature. Chlordiazepoxide is useful for tremulousness and mild to moderate agitation. Psychotic and perceptual symptoms may begin in 8 to 10 hours. If your patient is undergoing withdrawal to the point of psychosis, it should be considered a medical emergency because of the risks of unconsciousness, seizures, and delirium. The benzodiazepines lorazepam or chlordiazepoxide can be given either orally or intramuscularly and tapered over the following 5 to 7 days. Withdrawal seizures may occur within 12 to 24 hours after alcohol cessation. These seizures are generalized and tonic-clonic. Additional seizures may occur within hours of the first seizure. Diazepam given intravenously is a common treatment for withdrawal seizures. Alcohol withdrawal delirium, also known as delirium tremens, is a medical emergency that can result in the death in 20% of untreated patients, usually as a result of medical problems such as pneumonia, renal disease, hepatic insufficiency, or heart failure. Alcohol withdrawal delirium may happen anytime in the first 72 hours. Autonomic hyperactivity may result in tachycardia, diaphoresis, fever, anxiety, insomnia, and hypertension. Delusions and visual and tactile hallucinations are common in alcohol withdrawal delirium. Delusions and hallucinations may result in unpredictable behaviors as patients try to protect themselves from what they believe are genuine dangers. Patients on any medical floor are at risk for this condition after cessation of heavy drinking for 3 days and are a danger to themselves and others. Serious physical illness such as hepatitis or pancreatitis may increase the likelihood of alcohol withdrawal delirium. It is rare to see this syndrome in individuals in good physical health. Prevention of alcohol withdrawal delirium is the goal. Oral diazepam may be useful in the symptomatic relief of acute agitation, tremor, impending or acute DTs, and hallucinosis. Chlordiazepoxide may keep your patient out of danger. However, once delirium appears, intravenous lorazepam is used to treat these severe symptoms. Seclusion may be necessary. Dehydration, often exacerbated by diaphoresis and fever, can be corrected with oral or intravenous fluids. Cognitive disturbances. Wernicke-Korsakoff syndrome. People with a heavy use of alcohol for many years may suffer from short-term memory disturbances. One memory-reducing problem is Wernicke's encephalopathy, an acute and reversible condition. Another problem is Korsakoff syndrome, a chronic condition with a recovery rate of only about 20%. The pathophysiological connection between the two problems is a thiamine deficiency, which may be caused by poor nutrition associated with alcohol use or by the malabsorption of nutrients. Are bilateral but not necessarily symmetrical. Sluggish reaction to light and anisocoria are also symptoms. Wernicke's encephalopathy may clear up within a few weeks or may progress into Korsakoff's syndrome, the more severe and chronic version of this problem. Wernicke's encephalopathy responds rapidly to large doses of intravenous thiamine 2 to 3 times daily for 1 to 2 weeks. Treatment of Korsakoff syndrome is also thiamine for 3 to 12 months. Most patients with Korsakoff's syndrome never fully recover, although cognitive improvement may occur with thiamine and nutritional support. Blackouts. An extremely disturbing aspect of alcohol use is blackouts. Blackouts are caused by excessive consumption of alcohol followed by episodes of amnesia. During these periods of time, a person actively engages in behaviors, can perform complicated tasks, and appears normal. This phenomenon is due to alcohol's ability to block the consolidation of new memories into ones through the hippocampus and related temporal lobe structures. Fetal alcohol syndrome. Fetal alcohol syndrome is a common cause of intellectual disability in the United States. Alcohol during pregnancy inhibits intrauterine growth and postnatal development, resulting in microcephaly, craniofacial malformations, and limb and heart defects. As adults, affected individuals tend to have a short stature. Women with alcohol-related disorders have a 35% risk of having a child with defects. Peripheral neuropathy. Chronic alcoholism leads to nutritional deficiencies, particularly thiamine, due to drinking rather than eating, leading to damage to the peripheral nervous system. The feeling of pins and needles in the lower extremities is a common symptom of peripheral neuropathy. Other symptoms include numbness, muscle weakness, sensitivity to touch, and burning. Discontinuation of alcohol will prevent further deterioration. Alcoholic myopathy. Binge drinking may cause a sudden acute alcoholic myopathy with muscle weakness and myonecrosis, muscle damage. Chronic alcoholic myopathy develops gradually. The characteristic symptom of this problem is a significant reduction in muscle mass and resulting muscle weakness. Recovery is possible if alcohol is avoided, but the time to recovery varies from rapid with the acute form to lengthy with the chronic form. Alcoholic cardiomyopathy. Direct toxic effects of alcohol can weaken and thin the muscles of the heart, leading to enlargement and eventual heart failure. Symptoms of alcoholic cardiomyopathy are similar to other types of heart failure, including fatigue, shortness of breath, and edema of the legs and feet. Esophagitis. Inflammation of the esophagus is a direct result of the toxic effects of alcohol on the esophageal mucosa. The vomiting related to alcohol overuse is also contributory to this condition. Esophageal varices are distended veins within the esophagus or the upper part of the stomach that result from heavy drinking. These veins are at risk for bursting, which results in a medical emergency. Gastritis. As a toxin, alcohol irritates and erodes the mucosal stomach lining. Symptoms of gastritis include nausea, vomiting, loss of appetite, belching, and bloating. Damage to the stomach lining may lead to ulcers and bleeding. Pancreatitis. Prolonged and hazardous drinking may result in pancreatic damage. Excessive drinking, usually more than 5 years, may result in an acute attack of pancreatitis. Continued alcohol misuse eventually results in chronic pancreatitis in a minority of misusers. Abdominal pain, nausea, and vomiting are the major symptoms of acute pancreatitis. Withdrawal of alcohol in the early stages will reverse the condition. The chronic condition results in malnutrition, weight loss, and diabetes mellitus. Withdrawal of alcohol in the chronic condition may reduce inflammatory episodes and allow for better control of diabetes. Alcoholic hepatitis. Alcohol gets processed by the liver and produces highly toxic chemicals. Excessive alcohol over an extended period of time may result in a diseased and inflamed liver. Alcoholic hepatitis only occurs in a minority of heavy users. Genetic factors, such as how the body processes alcohol, other liver disorders, example, hepatitis C, malnutrition, and being female increase the risk of this disorder. Symptoms of alcoholic hepatitis include appetite changes, dry mouth, weight loss, nausea and vomiting, pain or swelling in the abdomen, jaundice, fever, confusion, and fatigue. Cirrhosis of the liver. Cirrhosis is a slowly progressing disease in which healthy liver tissue is replaced by tissue. Eventually, the liver can no longer function properly because the scar tissue blocks the flow of blood through the liver. This slows the processing of nutrients, hormones, drugs, and naturally produced toxins. Liver disease and cirrhosis was the 10th leading cause of death by disease in men in 2017. Symptoms of cirrhosis of the liver include easy bleeding and bruising, pruritus, jaundice, ascites, leg edema, weight loss, confusion, spider-like blood vessels on the skin, and testicular atrophy. No treatment will cure cirrhosis or repair scarring. Liver transplantation may be necessary. Low-salt diets will reduce ascites. Leukopenia. When there is liver damage, alcoholism may cause low white blood cells due to vitamin deficiencies and low protein intake. Low white blood cells predispose individuals to infection and disease. Symptoms of leukopenia include periodontitis and gingivitis, fatigue, weakness, fever, and abdominal pain. Improved nutrition and alcohol cessation are indicated for this condition. Thrombocytopenia. Thrombocytopenia is a complication of liver cirrhosis characterized by a low platelet count. This is caused by platelet pooling in an enlarged spleen and decreased thromboprotein production in the liver. Symptoms of cancer. Alcohol consumption is a major risk factor for head and neck cancers, especially in the head and neck, esophagus, oral cavity, pharynx, and larynx. Alcohol use is also associated with liver, breast, and colorectal cancers. Application of the nursing process. Screening. Alcohol is a major contributing factor in increased mortality and deaths, morbidity and disease, harm to others and injury, increased economic loss and disabilities. Alcohol can be fatal as a result of its severe withdrawal symptoms. Screening is essential to intervene early and Provide treatment for people with substance use disorders and for those at risk of developing these disorders. The screening, brief intervention, and referral to treatment program is a comprehensive, integrated, public health approach to the delivery of early intervention and treatment services for persons with substance use disorders as well as those who are at risk of developing these disorders. SPIRT identifies at-risk substance users for early intervention and consists of three major components. Screening: a nurse or other healthcare professional in any healthcare setting assesses the severity of substance use and identifies the appropriate level of treatment. Brief intervention: a nurse or other healthcare professional focuses on increasing insight and awareness regarding substance use and motivation toward behavioral change. Referral to treatment: a nurse or other healthcare professional provides those identified as needing more extensive treatment with access to specialty care. A variety of other screening tools are available to assist healthcare practitioners in gaining important information on which to base plans of care. Additional screening tools are audit, CAGE, questions. Have you felt you needed to cut down on your drinking? Are people annoyed by your drinking? Have you felt guilty about your drinking? Have you ever had a drink in the morning? A score of 2 or more is significant, although a score of 1 requires further assessment. CAGE Aid, TACE. Formalized alcohol screening is as simple as using the Alcohol Use Disorders Identification Test developed for the World Health Organization. Audit has been effective for decades and continues to be used today. Bakui et al. 2001, the clinician can administer this tool or the patient can self-report. During the screening process, instructions need to be clear and followed carefully. Non-judgmental attitudes help with objectivity regardless of what the individual reveals. Several trends are important, such as the appearance of progression or loss of control and whether or not tolerance or withdrawal is present. Once the screening process identifies a potential problem, a more complete assessment is warranted. Assessment: an alcohol use assessment is part of a more comprehensive assessment that evaluates the individual holistically. Ideally, this assessment involves an addiction professional with specialized knowledge and skills to make a diagnosis. The assessment will include a clinical examination of the background, pattern of substance use, and any mental health symptoms. The nurse will make special note of any history of trauma, a family history of substance use or mental health problems and any disabilities, as well as the individual's strengths and level of willingness to change. As a result of this assessment, the individual may be identified as having a substance-related disorder. Family assessment: understanding the process of addiction from a holistic perspective requires careful attention to the family living with an individual who misuses alcohol or other substances is a source of stress and requires family system adjustments. Codependence is a cluster of behaviors originally identified through research involving the families of alcoholic patients. People who are codependent often exhibit overly responsible behavior, doing for others what others could just as well do for themselves. People who are codependent often define their self-worth in terms of caring for others to the exclusion of their own needs. Self-assessment: alcohol use is self-inflicted. Carefully assessing personal thoughts, opinions, and feelings is the first step to remaining objective and establishing a therapeutic relationship with a person who misuses alcohol. Recognizing and dealing with our responses by practicing introspection is essential to the provision of patient-centered care. Protected from bias or countertransference. You may be aware that registered nurses themselves might have personal substance use problems. For those nurses who become aware that they are engaging in risk-taking behaviors or that one of their colleagues may be experiencing difficulties, there are non-punitive alternatives to discipline programs in the form of peer assistance. Many state boards of nursing have developed an alternative to discipline programs to help impaired nurses. 2. Determine if your state has this model. Check with your state's Board of Nursing. Nursing diagnosis. Once the comprehensive substance use assessment has been completed in a thorough, objective manner, the data are analyzed and potential or actual problems and needs are identified. Clinical decision-making skills will be used to determine which of the identified problems requires a priority intervention. Outcomes identification. The goals for treatment planning arise from the preferred outcome for each problem. Outcome measures may include immediate detox and stabilization for individuals experiencing withdrawal, abstinence if individuals are actively drinking, motivation for treatment and engagement in early abstinence, and pursuit of a recovery. Lifestyle for after discharge. Identifies signs and symptoms commonly experienced with substance use disorders, offers potential nursing diagnoses, and suggests outcomes. Planning. The treatment plan will be developed based on the assessment and diagnoses. For treatment to be successful, a patient-centered approach includes the patient's goals. The plan should take into account the patient's ability to recognize the problem and readiness or motivation for change. Table 225 Signs and symptoms, nursing diagnoses, and outcomes. For substance-related and addictive disorders. Signs and symptoms. Impulsiveness, loss of relationships. An occupation due to focus on substances or gambling, legal problems, social isolation. Intoxication, impaired cognition/judgment, impaired physical coordination, psychomotor. Agitation or retardation. Nursing diagnoses. Risk for suicide. Risk for injury. Outcomes. Decreased suicide risk, expresses feelings, verbalizes suicidal ideas. Refrains from suicide attempts. Plans for the future. Remains free from injury while intoxicated, depends on the overdosed substance. Example: opiates, unresponsiveness. Respiratory depression, pinpoint. Pupils, coma, hypothermia. Hypotension, bradycardia. Depends on the substance of withdrawal. Example: opiates, mood dysphoria. Nausea, muscle aches, fever, insomnia. Lacrimation, rhinorrhea, pupillary. Dilation, yawning, gooseflesh. Reports not feeling well rested. Decreased ability to function, reports. Awakening multiple times. Substance use or gambling, decreased. Use of social support, destructive. Behavior towards self and others. Difficulty organizing information. Inadequate problem solving, poor. Concentration, reports inability to cope. Does not perceive danger of substance use or gambling, minimizes symptoms. Refuses healthcare attention, unable to admit impact of disease on life pattern. Substance use or gambling, lack of initiative, passivity, social isolation. Reports no alternatives or personal control, anger, no meaning in life. Blaming, broken promises. Lying, enabling, manipulation. Rationalization, projection. Deterioration of family relationships. Overdose. Withdrawal. Impaired sleep. Impaired coping. Denial. Hopelessness. Dysfunctional family. Process. Overdose resolution. 2. Of. Pre-overdose. Functioning. Returns. Level. Identifies. Mechanism of overdose. Withdrawal cessation. Symptoms. Are controlled. Returns to pre-dash. Withdrawal functioning. Improved. Sleep. Minimal. Awakening. Feels restored after. Sleep. Sleeps recommended. Hours based on age. Effective coping. Modifies. Lifestyle as needed to maintain. Sobriety. Maintains abstinence from substances. Engages in satisfying relationships. No denial. Accepts responsibility for behavior. Maintains abstinence from substances. Expresses feelings of self-worth. Verbalizes sense of personal identity. Expresses meaning in life. Sets goals. Believes that actions impact outcomes. Improved family process. Identifies personal role in family dysfunction. Activities for increasing self-confidence and self-efficacy would also lower the risks for use of psychoactive substances. Social activities that increase supportive relationships reduce the impact of stressful life events and provide a venue for community activities that provide health education and promotion. Pay special attention to understanding the particular impact of trauma as a risk factor. Physical, sexual, or emotional abuse at any age. Physical trauma from accidents, natural disasters, or acts of violence or war can all be predisposing factors for the use of psychoactive substances or processes. Evaluation. Evaluation occurs on several levels, assessing the effectiveness of the treatment plan using objective data to check whether nursing actions address the patient's symptoms and measuring the changes in the patient's behaviors for progress toward meeting stated goals. Problematic behaviors, patterns of expression, or Perceptions may improve or only undergo changes in small increments, requiring alterations in the action steps, or even the goals of the treatment plan to meet the patient's needs. During the treatment experience, conduct ongoing evaluation of the process to ensure that any transference or countertransference is managed and that the goals and outcomes of treatment remain patient-centered. Evaluation will also make it possible to ensure that the patient acquires the necessary skills and competencies for continued reflection and maintenance of the new lifestyle identification. Treatment modalities: biological treatments, pharmacotherapy. Previously in the chapter, we discussed medications used for other substances. Table 226 identifies medications used in the treatment of alcohol use disorder. Psychological therapies. Advanced practice nurses and other substance use and addiction treatment professionals use a number of psychotherapies. Cognitive behavioral therapy and motivational interviewing are commonly used evidence-based therapies. Destructive and negative thinking patterns play into the development of maladaptive behavioral patterns like substance use disorders. Cognitive behavioral therapy helps patients explore thinking patterns so that the core belief system and any irrational core beliefs can be identified. Positive and negative consequences of alcohol use are explored. Patients learn to self-monitor their cravings and challenge these cravings realistically. Motivational interviewing is an approach based on the trans-theoretical or stages of change theory. It has gained popularity in its use as a brief, long-term, and supplementary intervention, particularly in the treatment of substance use disorders. It uses a person-centered approach to strengthen motivation for change. For N. Lee Lim, the advanced practice nurse and patient usually meet for an hour at a time. Individuals may be at stage 1, pre-contemplation, and need assistance in admitting there is a problem. If they have acknowledged the problem, contemplation, they may still not be ready to commit to addressing it. The goal of treatment is to assist in the development of awareness and a commitment. Preparation, or getting ready, and action, or changing, take place in early treatment phases. The maintenance stage is the ongoing commitment to a recovery program. Without continuing action, the individual will likely return to previous behavior, relapse. Care continuum for substance use disorders. Continuity of care occurs through a continuum starting with detoxification, rehabilitation, halfway houses, partial programs, intensive outpatient OOP, and outpatient settings. Mutual support groups, such as AA, are strongly encouraged throughout the treatment process. Table 226 Common medications used for treatment of alcohol use disorder. Generic: disulfiram, naltrexone, Vivitrol, injectable, Revia, Depade, oral. Uses: maintenance, relapse, prevention, aversion therapy, withdrawal, prevention, relapse. Decreases: implications for the therapeutic process. Physical effects when alcohol is used: intense nausea and vomiting, headache, diaphoresis, flushed skin, dyspnea, respiratory difficulties, and confusion. Avoid all alcohol and substances, such as cough syrup and mouthwash containing alcohol. Oral or long-acting. Injectable form. Nausea usually pleasurable. Cravings, feelings, and acamprosate calcium, benzodiazepines, lorazepam, chlordiazepoxide, diazepam. Anticonvulsants, barbiturates, clonidine. Relapse prevention. Withdrawal, mild to moderate withdrawal, goes away after first month. Headache, sedation, pain at injection site. Patient needs to be opiate-free 10 days before initiation of medication. Begin taking on the 5th day of abstinence from alcohol. Tablets are taken 3 times a day. Side effects include diarrhea, gastrointestinal upset, appetite loss, dizziness, anxiety, and difficulty sleeping. Contraindicated in patients with renal impairment, sedation, decreased anxiety, and blood pressure. Use CYAR scale to assess dose. According to agency policies, assess for seizures that could lead to delirium tremens. If not treated, coma and ultimately death. Older treatments still used today. Other treatments have proven more effective and safer. Assess for seizures that could lead to delirium tremens if not treated. coma, and ultimately death. Alpha agonist antihypertensive agent. Give every 4 to 6 hours as needed. Side effects: dizziness, hypotension, fatigue, and headache. Substance Abuse and Mental Health Services Administration and National Institute on Alcohol Abuse and Alcoholism. Medication for the Treatment of Alcohol Use Disorder, A Brief Guide. HHS Publication No. 15 to 4907, Rockville, Maryland. Author. Case Study and Nursing Care Plan. Alcohol Use Disorder. Mr. Stewart, aged 49 years, and his wife arrive in the emergency department. They are fearful that Mr. Stewart has had a stroke. His right hand is limp, and he is unable to hyperextend his right wrist and cannot feel his fingertips. Miss Winkler, the admitting nurse, begins the assessment. Mr. Stewart looks much older than his stated age. His complexion is ruddy and flushed. History taking is difficult. Mr. Stewart answers only what is asked, volunteering no additional information. He states that he took a nap that afternoon. When he woke up, he noticed the problems with his right arm. Mr. Stewart has been unemployed for 4 years because the company he worked for went bankrupt. He has been unable to find a job but has an interview in 10 days. His wife is now working full-time. They have 2 grown children who no longer live at home. As he talks about his children, his lips start to tremble and his eyes fill with tears. Meanwhile, a nurse practitioner has examined Mr. Stewart. The diagnosis is radial nerve palsy. Mr. Stewart most likely passed out while tying on his arm. Because Mr. Stewart was intoxicated, he did not feel the signals that his nerves sent out to warn him to move. He was in this position for so long that the resultant cutoff of circulation was sufficient to cause some temporary nerve damage. Mr. Stewart's blood alcohol level is 0.31 mg/dl. This is 3 times the legal limit for intoxication in many states. Despite the high alcohol level, Mr. Stewart is alert and oriented, not slurring his speech or giving any other outward signs of intoxication. This incongruence is likely due to tolerance, a symptom of physical addiction. Self-assessment. Ms. Winkler has seen many patients with the disease of alcoholism make radical changes in their lives, and she has earned to view alcoholism as a treatable disease. She is aware also that it is the patient who makes the changes, and she no longer feels responsible when a patient is not ready to make that change. Assessment. Subjective data. Complains of limpness in his right hand, inability to hyperextend his right wrist, and cannot feel his fingertips. Notice the problems with his arm after a nap. Unemployed for 4 years. Upcoming job interview. Objective data. Appears older than age. Complexion ruddy and flushed. Short responses, volunteers little information. Tearful when talking about children. Blood alcohol level is 0.31 mg/dl. Alert and oriented. Priority diagnosis. Impaired coping related to alcohol use as evidenced by increased alcohol use and impairment in life functioning. Outcomes identification. Client will demonstrate mild to no change in health status and social functioning due to substance addiction. Detoxification. Is learning about his triggers and new coping skills. His wife attends Al-Anon. Detox is warranted when the individual quits using a psychoactive substance known to cause withdrawal or when the individual is already in withdrawal. This is a medically managed inpatient program with 24-hour medical coverage while the patient's body clears itself of drugs. This process is accompanied by uncomfortable and even fatal side effects caused by withdrawal. Detox is also available as a medically monitored program with 24-hour professional supervision based on the severity of symptomatology and the presence of comorbid conditions. Rehabilitation. Residential rehabilitation programs are available as medically managed and medically monitored inpatient programs. The medically managed programs usually employ 24-hour medical staff and provide intensive and specialized care for those individuals with either medical or psychiatric comorbid conditions. They offer professionally directed evaluation and treatment in short-term settings for those with acute distress and moderate impairment and long-term settings for those with chronic distress or severe impairment. Short-term rehabilitation offers rehabilitation, while long-term rehabs offer habilitation, learning new skills. Halfway houses. Halfway houses offer residential treatment in a substance-free communal or family environment that provides opportunities for independent growth. Individuals continue the work started in other treatment programs, usually in a long or short-term residential rehabilitation center. The focus is on extending the period of sobriety, getting case management assistance in addressing educational, economic, and social needs, and integrating new life skills into a solid modeled recovery program. Most residents live in these halfway houses but work outside. Other housing opportunities for community reintegration are also available in supportive housing units that are not part of treatment. Three-quarter-way houses, therapeutic communities, and housing programs offer drug-free living environments, peer support, and classes to assist or remediate the skills needed for daily living. Residents usually attend some type of outpatient substance use treatment to continue in their recovery program. Partial hospitalization program. Partial hospitalization programs are an intensive form of outpatient programming for those individuals who do not need a 24-hour residential treatment, but who benefit from a structured treatment setting. Partial programs tend to run 5 days a week for about 6 hours a day with planned programming. This combination of psychotherapy and educational groups does not require the individual to have previous treatment experience. Participants may live in some type of supportive housing program or at an independent home. Medication management is available, but it is not usually medically monitored or managed in this setting. Intensive outpatient programs. An alternative to a partial hospitalization program is an IOP program. This is a non-residential program, highly structured with scheduled treatment groups and at least one individual session regularly. Medication management is usually available, but it will not be monitored. Participants attend at least 3 days a week for about 3 hours per day. Outpatient treatment. The least intensive form of substance use treatment is outpatient. Treatment may be a mix of individual sessions and educational or psychotherapy groups as determined by the individual's needs and the treatment goals. It is structured, drug-free, and non-residential programming consists of not more than 5 contact hours a week. Web-based interventions are also available for self-paced, anonymous collective participation in treatment efforts. Alcoholics Anonymous. AA was founded in 1930 and is the oldest and best known of the 12-step programs. Anyone with the desire to quit drinking or using substances is welcome to attend meetings. Individuals learn how to be sober through the support of other members and the 12 steps. In most suburban and urban areas, meetings can be found every day and around the clock. Meetings are even available online and are structured for confidentiality and anonymity. Family members and other support are often welcome. The 12-step model has been adopted worldwide. An internet search should reveal a 12-step program for any substance use problem in even specific populations, such as women, men, and certain groups. The size of meetings ranges from small to large. There are also meetings to address the special needs of family and significant others, such as Al-Anon for friends and family members and Alateen for teenage relatives. Relapse prevention. To maintain long-term sobriety, each individual must prepare for and anticipate the possibility of relapse. This includes identifying potential triggers to substance use, learning skills to regain abstinence in the event of use, and adopting healthy coping, identity, and stress management skills to address triggers before they threaten sobriety. Advances in technology have expanded options for maintaining long-term sobriety. Applications for smartphones, for example, offer a way to monitor behavioral patterns for relapse clues. Key points to remember. Substance-related and addictive disorders are complex brain diseases characterized by craving, seeking, and using regardless of consequences. Most substance use disorders are characterized by addiction, intoxication, tolerance, and withdrawal. The cause of substance use is a combination of biological and environmental factors. Assessment of patients with substance use problems needs to be comprehensive and aimed at identifying common medical and psychiatric comorbidities.